My dear doctors, you are working in an emergency department of a hospital. Suddenly, a 40-year-old female presents to you with the complaints like loss of consciousness, dyspnea, difficulty in breathing, and faint or no pulse. So, how will you manage this case? And all of the above symptoms may be pointing towards the cardiac disorder, that is sudden cardiac arrest. So the following symptoms points towards the cardiac disease that is known as sudden cardiac arrest. तो आज हम देखते हैं ये sudden cardiac arrest क्या होता है, लेकिन उससे पहले but before that we need to differentiate between what is sudden cardiac arrest and what is heart attack. So differentiating sudden cardiac arrests and heart attack is quite easy on the basis of the clinical symptoms presented by the patient. In sudden cardiac arrest, you can see the patient is unconsciousness and the pulse is either absent or very feeble pulse, and also the patient will be having difficulty in breathing. While in heart attack, the patient may be presenting with chest pain and pain or discomfort in one or both the arms, and it may be quite a specific type of radiating pain and lightheadedness or dizziness. So, my dear friends, what is sudden cardiac arrest? It is an abrupt loss of cardiac function resulting in complete cardiovascular system collapse. Most of the sudden cardiac arrests they occur outside the hospital, and only 10% of them survive despite undergoing attempted resuscitation by emergency medical services. Now, what are the causes and risk factor? The most common causes are the cardiomyopathies, inherited arrhythmias, valvular diseases, idiopathic ventricular fibrillation, coronary heart diseases, myocardial infarctions, and some of the trigger factors. Now, about the pathophysiology of the sudden cardiac arrest, most common cause is the myocardial infarction or the transient myocardial infarction leading to polymorphic VT and ventricular fibrillations. My dear doctors, in the absence of the structural heart diseases, ventricular fibrillation can also be due to the Brugada syndrome, long QT syndromes, or the WPW syndromes associated with rapid atrial filling. Pulseless electrical ordinance can also result from pulmonary emboli or the terminal phase of the respiratory arrest. Out of hospital chain of survival, we have four steps. First one is initial recognition and the evaluation of the sudden cardiac arrest. And the second is the rapid initiation of the CPR along with the chest compressions. The third is the defibrillation with the automatic external defibrillators. And the fourth is the advanced life support and post cardiac care. So for the initial evaluation and initiation of CPR, we should first of all check the response from the victim and shout out for help and call or ask someone to call their local emergency number. And also we should keep the phone on the speaker mode so that we can provide the necessary information regarding the victim, and also the dispatcher can provide some of the instructions and queries regarding the patients. So aspiration or airway obstruction is very important, and if there is any airway obstruction, we can perform the Heimlich maneuver. So, a trained healthcare provider would also check for a pulse, but no longer for 10 seconds. In order, we should not delay for the chest compressions. Now, gasping respirations and brief seizure activity are common during the sudden cardiac arrest. Now, chest compressions should be initiated without delay and administered at a rate of 100 to 120 chest compressions per minute. So the chest compressions should be initiated without any delay and should be administered at a rate of 100 to 120 per minute by depressing sternum 5 cm, that is 2 inches, and allowing full chest recoil between compressions. Interruptions of the chest compression should be minimized in order to reduce the end organ ischemia. Now, 2 breaths for every 30 compressions for a trained rescuer, but for a lay person, only hand chest compressions are enough. Chest compressions are continued while the defibrillator is being charged. As soon as the diagnosis of ventricular fibrillation or ventricular tachycardia is made, a 200 joule biphasic waveform shock should be administered. Chest compressions are resumed immediately, continue for 2 minutes until the next rhythm check. If VT or ventricular fibrillation is still present, a second maximal energy shock is delivered. This sequence is continued until personnel to administer advanced life support are available or the return of spontaneous circulation is achieved. Epinephrine 1 mg every 3 to 5 minutes may be administered intravenously or intraosseously. If a second rescuer is present, then we should send him to bring the automated external defibrillator. If circulation is not restored, acidosis or hypoxia may be diagnosed with the help of arterial blood gases. If metabolic acidosis persists after successful defibrillation, sodium bicarbonate should be administered. If ventricular tachycardia or ventricular fibrillation still persists after one or two more successful shocks, amiodarone may be administered as a bolus via intraosseous or intravenous route. Pulseless electrical alternance should be managed with CPR, ventilation, and administration of epinephrine. Hope so you like the information. For such interesting topics, please do like, share, and subscribe.